Welcome everyone to this presentation this evening on the crashing adult. My name is Dr. Benjamin Ashira. I'm an emergency physician based in Nairobi, Kenya. And yes, I love resuscitation and excited about taking you through today's presentation. So a lot of people joining here probably have experienced a crashing patient and have been in a situation where they need to resuscitate a patient. Just a caveat, this discussion has nothing to do with CPR or, yes, the CPR intubation can like the patient who is pulseless. Our target for now is that peri-arrest, a patient who, if you do not intervene, then the patient potentially will die or will crash and then you'll have to resuscitate. So pretty much, ideally, prevention is better than cure. So being able to stop a patient from crashing is a unique skill that potentially prevents you having to go down the whole resuscitation pathway. All right, so this is part of our webinar series as the Emergency Medicine Kenya Foundation that we'll be having this month every Thursday, 7 to 8:30. We'll just be discussing basics of resuscitation. So make sure you subscribe to the emails from Dr. A Online. This is in partnership with Dr. A Online. And join us as we go through an exciting series on how to manage very sick patients in the emergency care setting and what you can do in your capacity. And just the idea behind this is just discuss the basic approaches. All right. So this, if you don't remember anything, this is actually the summary of my whole presentation. Okay. The approach to any patient who's crashing goes through 6 basic points. It's the first, of course, is do they have a pulse, yes or no? Of course, if they do not have a pulse, then you need to start CPR. But if they have a pulse, then you're good. Next part of it is you need to know whether there was trauma involved, yes or no. Important part behind this is then you need to know whether to do C-spine protection or don't need to do C-spine protection. But also in a trauma patient, then you're looking for other potential. Your scope of what could potentially be causing your patient to crash expands significantly. And so you need to consider other factors that come with trauma. The other part of it is their airway. So I know we all know that we're always saying ABCD, anything ABCD, ABCD. So today we're going to just go deeper bits into what exactly, when we say ABCD, what exactly do we mean? All right. Is it just airway breathing circulation? We all have it like a mantra, but what exactly does it mean? So for the airway, the key questions you're asking yourself at any point is it open? Is it maintainable? Do you need to intubate? Those are the 3 main questions in any patient's airway. That is the patient's airway open? Can they maintain their own airway? Or do I need to intubate the patient? Okay. For breathing, we use RACEs. So RACEs is in the mnemonic that works for breathing and circulation. So RACEs, you look at the breathing rate, the air entry, the color of the patient, the cyanosed or not cyanosed, effort of breathing, and what's their saturations like. That's your breathing assessment. In circulation, of course, then you're looking at the same also RACEs, but this time you're looking at your heart rate, your level of consciousness based on the ABPU scale, the patient's color, are they pale, okay, are they poorly perfused, get an ECG on the patient, of course, and then your systolic blood pressure. And on disability, the main thing is you want to calculate a GCS, you want to check your pupils, and then you want to check a blood sugar. And I can guarantee you in any single patient, if you follow these basic principles, you'll be able to actually manage any crashing patient. And remember, as you find something, you fix it. So as you go down the line, you need to provide the resuscitative measures to your patients. So not just about identifying them, but providing the resuscitation measures. So this is a simple 6-step process I use on any single patient coming in through the ED is there a pulse, yes or no? All right. Is there trauma involved? Yes or no? Good. So then we know where we're starting from. All right. Airway. Are they talking to me? That's fine. They're open. They're maintaining it. That's fine. I don't need to intubate them. What's their breathing? Are they breathing too fast? When I auscultate, what's the air entry? Are they getting cyanosed from poor breathing? Are they struggling to breathe? What's their saturations? And then do I need to give oxygen? Circulation, then we're looking at what's your rate, your heart rate mainly, is it too fast, too slow? What's your level of consciousness? What color? Are they pale? Are they cold, clammy, looking ashen? What's the ECG doing? Or just systolic blood pressure? And disability, GCS, pupils, RBS. I can guarantee you every critically ill patient this has to be, you have to get all these things. And the main thing is actually having a routine of how you do it at every given point, and being able to provide the immediate statistical efforts that your patient needs. All right, so let's have a look at some cases. So here's one patient.
I'm gonna come around. Sir, are you her husband? Yes. Okay.
All right, so you've just seen that patient. Okay, they've just landed in your emergency department. All right, so there's a poll question that's coming on your screen now. What's your approach to this patient? Okay, what's the first question in your head about this patient? So correctly, majority of you asking, yes, is there a pulse? That's the first and most important question about this patient. The question about her BP doesn't really help us at this point because A, you need a pulse to have a BP. Her level of consciousness, we already can tell she's unconscious, okay? And that will be dealt with a bit later. But the question is, does she have a pulse? Because if she doesn't have a pulse, we are starting CPR, okay? Immediately, no discussions about this. If she has a pulse, then we're going down into doing what's the next thing. So that's the first question. Any patient, especially an unconscious patient showing up, do they have a pulse? Okay, am I starting CPR or am I not starting CPR? Okay, in terms of our SpO2, you actually realize you need to have a pulse to get your SpO2. Okay, your pulse oximeter is dependent on you having a pulse, so that necessarily will not actually work. And so the pulse is the first thing. You need a pulse to get a BP, you need a pulse to have SpO2, but you also need a pulse to have a level of consciousness, and you also need a pulse so you know whether you're starting CPR or not. So good job on that. Okay, good. So that's the correct answer on that one. Okay, so let's go. So the question is yes. Approach, yes. Patient has just been brought in, dumped on the emergency bed, or you pick them up in the ambulance. Do they have a pulse? Yes or no? Okay, that's the first question and most important question at this particular point. Okay, so here's the next question. So I'm gonna share this as a poll. What's your next question? So the first question was, does she have a pulse? Okay. So in this particular case, we are like, all right, so there's a pulse. So good. So the next question is there a history of trauma? Why is that important? Purely because it's at this point you want to start your C-spine protection measures in case there was a history of trauma, okay? You cannot start doing C-spine protections. Remember, as you're going down the algorithm, you'll be doing maneuvers that will potentially be moving your patient's neck in multiple ways. So you need to be able to know how much airway, how much neck protection I will require for my patient. So there's a pulse, good. Is there trauma? Quickly, if it's trauma, then I'm putting head blocks, blanket rolls to maintain the C-spine. And that, of course, alerts us throughout the next parts of the resuscitation that this patient needs C-spine protections, they were involved in a trauma accident. But I also said again, the other thing about trauma is it also alerts you to potential pathologies that the patient may have that are distinct to trauma versus your medical patients. So first thing is there a pulse? If my patient has a pulse, if there's no pulse, we're starting CPR and going down that whole CPR route. If my patient has a pulse, the next thing is like, is there trauma? Or suspicion of trauma. If there's a suspicion of trauma, then I can definitely need to immobilize the spine and of course make sure the spine is well immobilized. If there's no trauma, then we're good. Okay, I can do my head tilt chin lift without any issues. I can intubate my patient with the neck moving all over. I can do whatever I want to the patient without worrying that I'll harm their C-spine. Okay, so again, so it's still the principles. We're still going down the initial assessment. So for the pulse, we checked it earlier. GCS, not yet. We are not even there yet. GCS is one of those things that you figure out down the line, okay? SpO2 is going to come up, okay? It's going to come up in the discussion. And as I said, as you go down your ABCs, then you actually look and see what are your priority areas. So our first priority for this patient is going down. So our first question was, is there a pulse? Yes or no? So in this particular patient, there was a pulse. Okay. Was there trauma involved? So in this particular patient, there is no trauma. Okay. So just remember this patient because she's going to come back in our discussions. So far we've established Yes, she has a pulse, and no, there was no trauma. Besides, if you saw how she was moved on that gurney, you're praying she doesn't have trauma. Because in a patient who has trauma, then you need to make sure you're log rolling the patient appropriately, you're moving the patient as a block to protect the spine. All right, let's go to next patient.
He's fainted. Have Ingrid bring the oxygen. Jim?
So this is in a dentist chair. Patient has fainted.
Jim?
So what's your immediate concern with this patient? If the patient has a pulse, because we've established they have a pulse, what's your immediate concern about this patient? Okay, so this patient has a pulse, all right? So they've just fainted in the dental chair's office. And if you actually watch the video keenly, is the dentist is attempting to open the airway with a jaw thrust, because that's a fast thing. So we've established it was a pulse. He's on a dental chair, so he's not having any trauma. The next and most important thing is my airway open? Okay, so is my airway open? And that's what the dentist was trying to do by the jaw thrust. In the jaw thrust, you can either do a head to chin lift or you can do a jaw thrust, and that's what the dentist was trying to do. And yeah, so good. No one thought this patient needs to be intubated just yet. Patient needs oxygen. We're gonna discuss that a bit down the line a bit. But you remember, you need an open airway for you to breathe the oxygen. If your airway is closed, no amount of oxygen is going to help you breathe. So that's another thing. Is the patient talking is more an assessment of their level of consciousness. But of course, if they're talking, then they will tell you they're open. But you could have a patient who is not talking but has an open airway. So the first and most important part of the question is the patient's airway open? And at this point, so just going through this. So patient has a pulse, yes. Okay, no, it was on a dental chair, so definitely no trauma on that one. All right, and airway. So that's the question. Is the main question you ask yourself is this patient's airway open? Okay, is it maintainable? So the dentist automatically did a jaw thrust to open the airway. Okay, so question is it maintainable? That means if he let go, then the air would collapse, potentially not maintainable. Then a decision at this point will need to be made about, does this patient need to be intubated? Okay, so that's the next thing that we discussed, the next point of discussion. So is the airway open? So when they say open means patient is breathing spontaneously, patient is able to, they're either talking to you, if they're talking to you, they're fine, then you know their airway is open. But some patients, for example, between your GCSs of 15 to 8, your patient could be breathing spontaneously and could be maintaining their airway. GCS is below 8, then your patient's probably not going to be able to maintain that airway themselves and need to be intubated. Similarly, again, and how do you maintain an airway? But you could, if your patient has no gag reflex, you could put an OPA or pharyngeal airway to maintain the airway. You could put nasopharyngeal airways to maintain the airway. But in patients with a low GCS below 8, then those ones probably need to be intubated at this point. So this is a point where we're like, okay, my patient has a pulse, airway is not maintainable, the GCS is too low, they're not breathing effectively. I have to do a jaw thrust to keep the airway open. If I release the jaw thrust, the airway closes. We have to intubate this patient. We're not going any further. We have to provide an advanced airway. And the advanced airway can be you putting in ET tube, or you could be putting a supraglottic airway, your LMAs, your laryngeal tubes. So anything that is an advanced airway can be put at this point to maintain the airway. Rarely will an OPA on its own work in a patient with a GCS less than 8. In some patients, if they don't have a gag reflex between 15 to around 8, you can put an OPA, but most of them have a gag reflex, so they'll tend to vomit sometimes. So just be careful about that one. So key question is, pulse, yes. Trauma, no, they're on a dental chair. They didn't fall off the chair. Is the airway open or maintainable, or do I need to intubate? In this particular case, the dentist has opened the airway, and we'll be assessing this further to decide whether they need to intubate the patient or not. All right, here's the next case.
Mr. Lamb, are you okay? Here, let's sit you up a bit. What's going on? Having trouble breathing. All right. Doctor? We need a doctor.
Hello, Mr. Lamb. My name is Dr. Brown. I'm the resident on call tonight. This is Jennifer. She's a medical student who's drilling along with me.
He's just one day post-op laparoscopy. He just walked in the room and he's really having trouble breathing.
So let's have a look at his vital signs. All right, there you can see, so the nurse is connecting the patient to the monitor. He's running a tachy at 132, at 130. He's saturating at 82% on room air. And let's just check his BP. Okay, that should give us a BP. Let's need to get rid of a window here in front of me. There. All right, so his BP is, let me just see, this is 90/60. Yes, I just need to get 90/60. All right, so my next question would be on this particular patient, what's the immediate management for this patient? So our patient is post-op and presents with shortness of breath. If we look at his vital signs again, he's running tachy at 130. His SpO2s are 82. So that's a fasting flag. So remember, if we are going down his assessment, so does he have a pulse? Yes. Okay. Is there trauma involved? No, we've just been told he's post-op and for laparotomy or something. So no trauma involved. He's talking to us, okay? So that means his airway is open. Now the question, someone has asked the question in the chat is, what do you mean by maintainable? Maintainable means where either the patient by themselves will keep their airway open. Remember, your greatest risk for a patient lying supine is the tongue falling to the back of the throat and blocking the airway. So in patients who have GCSs above 8, are able to actually still maintain, they still have a gag reflex, a good number of them, and they're able to keep the tongue away from the back of the throat. In some instances, you may need to put an OPA, but in such cases, the patient probably has no gag reflex. So that's normally just probably pre-intubation. So that's what we mean by maintainable, meaning I can keep the airway open. I don't need to intubate right now, but I can keep the airway open. Either the patient can keep the airway open by themselves, or I can artificially keep it open using a device, okay? Oropharyngeal, nasopharyngeal airway. All right, that's what I mean by maintainable. Now, his breathing rate, okay? So his rate is in the 30s. So now we are assessing his breathing. His rate is on the 30s. It's a bit fast. Auscultation on his chest. He did not have any, well, we have to listen to actually tell what's happening in the chest, but he seemed to be moving air quite well. He was not cyanosed, okay? His effort, he was tachypnic, okay? So, but he wasn't struggling. We'll see the difference between just tachypnea and the patient who's struggling to breathe. But his SpO2 was in the 80s, okay? And that's the correct answer of the patient needs oxygen. So patient is talking, he doesn't need intubation yet, okay? But he needs oxygen because he's hypoxic. Yes, the immediate management right now. So monitoring, we've already done that. That's where we got the vitals from. And he doesn't need to be ventilated because he's breathing spontaneously. He's talking to us. He's just a bit tachypnic, a bit short of breath, and he's hypoxic. So he needs oxygen. So that's the main thing. So reviewing our plan here. So breathing, when you're assessing the rate, is it too fast or too slow? Or is it adequate? Is it air entry? Is there good air entry bilaterally in the chest? Okay. So the rate, if it's too slow, then you may need to start ventilating the patient. So that would be a good answer for a patient who's breathing too slow. Okay. If it's too fast, that's also a patient who down the line may need non-invasive ventilation because you can't punt away breathing at 100 per minute. And eventually you get quite tired. So a patient breathing too slow will probably need to be ventilated. And this is where we're talking about back valve mask ventilation and intubation and ventilation for this particular patient. A patient breathing too fast, okay, cannot sustain that rate for a very long time. And ideally, will either need to be started on non-invasive ventilation to support their ventilation, or down the line may need to be intubated depending on what the cause is. Air entry, okay, so you want to listen to the chest because if you have things like a tension pneumothorax that need to be decompressed at this point, if you have fluid in one side of the chest, like TB with a massive pleural effusion, you'll pick it up potentially at this point, and that can be relieved. That may be helpful, okay? If your patient is becoming cyanotic, okay, that means they're getting hypoxic, and they need They need supplemental oxygen. Effort, are they struggling to breathe? Because if your patient is struggling to breathe, then they can only struggle for so long before they stop breathing completely. So patient struggling to breathe, and it's either it's an asthmatic attack or a COPD exacerbation that you're relieving it, or it's something that needs assisted ventilation, for example, in use of non-invasive ventilation in your heart failure patients, or it's a patient who downright needs to be intubated and ventilated. So a patient who's struggling to breathe can only struggle for so long before they stop breathing. So intervening early will prevent you starting a resuscitation down the line. Okay. And then, of course, if you only need to give patients oxygen if they're hypoxic. If they're not hypoxic, you don't need to give them oxygen. So far, so good. Well done. Let's go to the next case. So this is the next case. Let me know what you guys think. So you can see his vital signs. Okay. Running a tachy. He's saturating at 100. His respiratory is 30. His BPs are still 90, 60. All right. Okay, so let's go to the next question. So what's your immediate management for this patient? So our approach to our patient still remains the same. Okay. Does the patient have a pulse? Yes. Okay. We was clearly seeing that on the heart rate monitor, patients seem to be breathing spontaneously. So pulse, yes. Okay. Trauma, no. Okay. There's no information that we have at this point, but he was propped up, no C-spine mobilization paraphernalia. So for sure, no trauma. Okay. Or at least the C-spine had been cleared in this particular point. Now, was his airway open, maintainable, or did we need to intubate? Okay. So patient was breathing. He was saturating at 100%. Okay. So patient was saturating at 100%, which negates the need to actually give him any oxygen. There's no saturations of 150%. No, you can only get to 100. That's a max. Okay. So this patient did not need oxygen. They were saturating well. Okay. In terms, so at this point, they don't need oxygen, but question of airway maintainable or intubate. Patient was having which is the question is, was this patient having an airway problem or was this patient having a breathing problem? Okay, because they were moving air, okay, at this particular point, they were moving air, okay. And in the flow of sequence, we are at the breathing point. They were moving air and they're moving it at 100%, okay. So for now, we can say we were moving air effectively, okay, and somehow we were maintaining the airway. Okay. Now, breathing. Okay. His rate was off. It was too fast. His air entry, you'd have to auscultate to hear that it was equally entry bilaterally. He was looking a bit grayish in terms of color. His effort, he was struggling. Okay. You could see the intercostal, intercostal recessions in an adult. That is real struggles. Okay. But his saturations are fine. Okay, so saturation was fine. So he seemed to have, in my opinion, and we can discuss it, and I'm happy to see the chat and the questions, is he had a breathing problem, okay, not an airway problem at this particular point, okay? So why I can say that is then we can say he can get non-invasive ventilation, okay, versus intubate. Remember, you don't have to intubate any patient who just needs ventilatory support. You can have non-invasive ventilation, and you need to distinguish the two. Do I need to just ventilate this patient, or do I need to ventilate and protect their airway at the same time? Okay. So some patients, especially your heart failure patients, your COPD who may need some support, a lot of them have good airways. The issue is they are not breathing effectively. So we can happily support your ventilation without having to intubate you. Okay, so that was a tricky part in this discussion. Let's see what the chat questions are. I see Bahati Moset. Yes, he's not ventilating. He has a breathing problem. I think he's sure the same. Confusing a bit. Okay. Omar Wale, maybe you can clarify what's confusing. Hello, guys. Tachycardia, tachypnea, accessory muscle use. Yes, that was clearly picked up. Non-invasive ventilation will ease the tachypnea. All right. Now, how non-invasive ventilation, and you guys should make sure you come for the rest of the discussions this month on this resuscitation. Now, non-invasive ventilation is one of those machines where you get a mask put on your face that blows air in, or you can have it for a high flow nasal cannulas. That's also non-invasive ventilation mode. So what happens is, remember, for you to breathe in, you need to pretty much your respiratory muscles, your diaphragm contracts. Those remember the bucket handle effect thing. Your respiratory muscle collapses, you get a negative pressure, air flows in, okay? And so there's a lot of muscle activity to do that, okay? Eventually, when you're doing that with a lot of effort, your muscles get tired. Okay, so how non-invasive ventilation works is the moment you start having that effect, the machine blows air into your lungs. That means you don't have to use all your muscle effort to get air into the lungs. Okay, so that's how non-invasive ventilation supports ventilation, meaning instead of you having to do all the work of breathing in terms of your diaphragm muscle relaxing and your ribs splinting out using respiratory muscles, then your machine just blows their air into you using a face mask or high nasal flow cannulas. When I say face mask, I mean the one that doesn't leak all over the place. And then that blows air into your chest and that helps you breathe, okay? So that would helps you relieve your ease of breathing. So it'll ease your tachypnea from the perspective of you will not be using your respiratory muscles as much to breathe, and that's less fatigue on you as a patient, okay? This works well in some conditions. So things like COPD exacerbations, things like heart failure patients, even some pneumonia patients will do well with non-invasive ventilation, okay? But there are patients who non-invasive ventilation will probably not work as effectively. And these are, of course, any patient who needs airway protection, for sure, any patient with excessive secretion, any patients with a depressed level of consciousness. You must be awake, alert, for you to allow that mask. Your confused patient will not tolerate the mask. So non-invasive ventilation helps you with easing off the use of your respiratory muscles when you're breathing. What would be the rate of flow of oxygen? In this particular patient, for example, who was doing 100% based on what you're seeing on room air, you just need minimal oxygen. You don't need as much oxygen. So a lot of it can be air driven. How do you assess color on African skin tones? It depends on how dark the skin is. So sometimes if it's too dark, you will not assess. If it's lighter skin, you may be able to pick it up. But it's something to look out for, especially around your mucous membranes, which are lighter colored. I mean, you don't go looking at the darkest part of the skin. But yes, sure, color of the lips, color of the tongue is a good way to assess the patient's color. So you're trying to identify features of cyanosis on the patient by looking at this. All right. So again, just stop sharing that. All right. Okay, let me close that. So yeah, so we can say, so breathing, what's the rate, what's the air entry, what's the color, effort, and SpO2. If the patient is getting oxygen, then monitoring him would be the priority here, since he was already ventilated. And no, this patient was not ventilator intubated. He was just breathing quite tachypnic. He was not on a ventilator. And that's why if he was on a ventilator, you will not see intercostal recessions. Intercostal recession shows you the patient is the one generating the negative. Remember, the negative pressure that's being generated is what's causing the intercostal recession. So you would not be having that if a patient was ventilated. All right, good. Good questions below the eyelids too. You can check the eyelids and see that. That's good also for checking for pallor. All right, good. I see we are all engaged, trying to keep these patients alive. All right, let's see who's the next patient.
Hey, Nicole, what's going on?
Looks like postpartum hemorrhage, bleeding for a little while, real weak pulses.
Greg, you have an airway?
Yeah, airway's good. She's just breathing very shallow.
Okay.
Get her on the monitor.
We'll call RT. Get RT down here, please, and have them set up for intubation.
All right, pressure cycling, real weak radial. I've got it.
All right, we still have continued bleeding here.
So quick assessment from where we remember this patient. If you've heard correctly, so the patient, yes, there's a pulse. Two, there's no history of trauma. She actually has postpartum hemorrhage and has presented in extreme shock from the bleeding. If you look at airway, if you actually listen to the conversation, like airway is good. She's just having shallow breaths. Okay. So she's just having shallow breaths, and the person at the airway decided to put the patient on oxygen as a prophylaxis. We don't know what her SATs are at that particular point. Okay. And then they continue, but you can hear they're talking about we will intubate. So the question someone was asking about maintainable, this patient has a maintainable airway. They have a bit of a depressed level of consciousness, but they're breathing spontaneously. They're not obstructing their airway. And yes, down the line, will she need to be intubated? Potentially, yes. But at this particular point, we are happy because she's moving air and we can supplement our oxygen. But want to see what her oxygen levels were prior to this, because too much oxygen is harmful in some of these patients. So it's always good to check your SpO2 before. And they've already come up with a story. So she has postpartum hemorrhage. So let's see what her vital signs look like. All right, let's check her blood pressure. So she's running a tachy. She's saturating well, which is fine, which is good. Okay. Her shallow breathing, she's at 17 breaths per minute. Her BP, as you can note here, is quite low. She's at 81/40 something. Okay, so quite lower blood pressure. Okay. All right. So good. So let's see. Let's go to the questions now and see. So what do you guys think? Does this patient need intubation? Do they need oxygen? Do they need fluid resuscitation? Do they need inotropes? All right. So our patient is bleeding. Okay. All right. So we let's assess the patient together from the top there. So is there a pulse? Yes. Okay. Is there trauma? Well, not really. I mean, well, there's hemorrhage, postpartum hemorrhage. Birth is a bit traumatic, but yeah, no real trauma that involves the spine. Airway, as correctly said, it's open. It's maintainable for now. Okay. But down the line, patient may need to be intubated. Okay. So open airway, is it open? Yes. Is she maintaining it by herself? Yes. Does this patient need to be intubated? Potentially, yes, but not at this particular point. But yes, down the line, she may need to be intubated. All right, let's look at breathing. Okay, so noted her breathing rate was 17. Air entry and auscultation ideally should be clear, unless she has any other issues. She was looking pale, and not just because she was white, but yeah. And yes, she has issues of postpartum hemorrhage. Effort of breathing was very poor. Okay, and that's also one of the issues that may lead you to intubate this patient earlier. Her effort of breathing was not that great, but for now, she was maintaining her saturations well. Okay, so she was maintaining her saturations well. So we quickly then moved to, and she was put on oxygen, so she was saturating well on oxygen. So we go to the circulation. Her heart rate was quite low, quite high, so she was running at tachy at 130. Her level of consciousness, we use the ABPU, alert, voice, responsive to pain or unresponsive. So this patient, just basically looking at her from this presentation, looked to be unresponsive. I put her at a U because there was no clear assessment of her level of consciousness. Carla says she's pale and that could be from bleeding. Her ECG on the monitor showed a sinus tachycardia. Her blood pressure was low at 80/40 something, so she was hypotensive. So correctly, so does this patient need intubation? The answer is yes. Does she need intubation now? No. Okay, so if especially a patient who needs intubation who is crashing, intubation will finish them. Okay, so if whatever reserve your patient had prior to intubation, the moment you decide to start intubating, your patient will crash and die. Okay, so there's a big drive towards resuscitate before you intubate, because if your patient's blood pressure is 80/40, the moment you give your paralytic and your sedative, your patient's blood pressure will disappear from your screen, and so will your patient. Okay, so do they need to be intubated? Yes, but first they need to be resuscitated first. Okay, bring their vitals up a bit, then potentially down the line proceed to intubation. Do they need oxygen? They already were on oxygen. I don't know what the stats were before, but yes, at this point, probably need to be oxygenated. The oxygen here would also be good because down the line, they're going to be intubated, so you can pre-oxygenate them prior to intubation. Yes, we all agree that she needs fluid resuscitation. Now, fluid resuscitation depends here at this point, it's which fluid, okay? She's bleeding, ideally she needs blood, okay? So you can start off with the crystalloids, but your priority is to get her blood. She's not bleeding normal saline, she's not bleeding Ringer's lactate. And we have a discussion on shock. I think it's next week or next week, but one of the Thursdays. We have a discussion on shock, and we'll discuss more about fluid resuscitation and blood and when it needs to be given when. Does she need inotropes? Not just yet. No, this patient has lost a lot of volume. She's not, what can I say? She's not having a pump issue. Again, more discussions around the shocked patient. So for right now, she needs more of fluid than anything else, and ideally should be getting more blood. And there's a lot of chats. So let's go to the chats. Patient needs blood. I think we came in late. What was our GCS? Patient, the GCS has not been calculated yet. She is currently just unresponsive. We've not done a formal assessment on that patient. What inotrope? We will not be putting her on inotropes yet. Remember, she's just bleeding. So for now, we need to do some volume resuscitation before we consider putting on any inotropic support at this point. So no inotropes at this point. Patient needs blood. Yes, Paul. Definitely this patient needs blood. Patient has signs of shock and she has PPH. She needs volume resuscitation, initially with crystalloids, but targeting to get her onto blood transfusion as soon as possible. Yes, the doctor also palpating the uterus. I don't know what that was supposed to be doing, but yes, she has PPH. Saline or Ringer's lactate. There's a lot of fights around this. People don't like, so we come for the shock. I think it's not this weekend, not next, I think it's next Thursday. I need to check that one. There's a whole talk on shock, and we'll discuss these fluids, saline or Ringer's. Scientifically, no real difference between saline and Ringer's, okay? And they've done multiple studies trying to prove one over the other, and it's always swinging left, right? I prefer Ringer's lactate because it's more physiological from a pH perspective versus normal. Ringer's lactate has a pH of 6.5, saline has a pH of 5.5, so I prefer Ringer's. And then chloride has a lot of issues, especially if you're in renal failure. But that discussion will come in shock. Resuscitation for yes, Kishore, resuscitation fast and then intubation is very important thing to follow. And very important. Yeah. Do not rush to intubate a patient who's crashing. You will kill them. Just simply put, you will finish what's left of that patient. Resuscitate fast, maintain your airway by any other means possible, but do not rush to put your RSI drugs into that patient who's crashing, because you will just be nailing that coffin shut at the end of it all. And we have a question. What's her GCS? Yes, it's not calculated on this video, sorry. But she is unconscious at this particular point. All right, good. Let's go to the next patient. All right, here we go. Okay, good. Let's check up her vital signs. There are her vital signs. Let's check her blood pressure. So our patient of note, she's running a tachy at 111. She's saturating well at 100. She's quite tachypnic. She's running a rate of 36 breaths per minute. That's quite fast. BP is not that bad, 112 something. I can see it at the bottom here. All right. So let's go back to our talk and see where we are at. Okay, what's the immediate management for this patient? All right. So if you can see, the patient's mouth is well open. Patient is just tachypnic. Patient is not on any oxygen. She's just breathing. If you just note her respiratory, she's, apart from tachypnea, doesn't seem to have any struggles. All right, you can see her JVPs are up there. All right, so question. So let's eliminate a few things here. Okay, does this patient need oxygen? No, they were saturating at 100%. Okay, They did not need oxygen at this particular point. Patient was saturating at 100%. All right. Now, does the patient need intubation? Really? I mean, their airway mouth was open. They were just lying flat and were maintaining their airway perfectly well. Again, a level of consciousness. So if we look at your assessment, if we look at our assessment, that's why assessing circulation comes in with an assessment of a level of consciousness. So we do not know what her level of consciousness is, but mouth was open, she was breathing quite just fast, not seems in any distress, apart from the tachypnea, no other obvious respiratory distress. ECG just shows a tachycardia. Color, I didn't see any cyanosis from where I was looking at. BPs were fine. She was at 110 something. So let me see, what are the questions? Okay, lost you, didn't get the question. All right. Tachypnea, shallow breaths, poor respiratory effort. Oops, lost you, didn't get the question. Looks like adult grunting to me. I wouldn't hear any sounds. There was no grunting now. Chest rising indicates patient's airway, patent airway, potentially. Okay, well, she's moving air. Let me put it that way. She was moving air in and out of her chest. So it doesn't necessarily guarantee a patent airway. Like, well, it's open. The airway is open. That answers that question because she's moving air. We can see she's moving air. We can't hear any sounds, and I like what Romeo was thinking of talking about, grunting. We can't hear any sounds coming from the airway, so that means the airway is open. Question, is it maintainable? For now, I guess she's lying flat, but will she need to be intubated down the line? Potentially, yes. Poor resp effort, she was running a tachypnea, but her chest was rising quite well. Let's look at that again, because when you say effort, okay, let's look at her chest effort. I mean, her breathing effort. She has a significant amount of chest rise, okay? So she is tachypnic for sure, okay? It's fortunately we don't have a face to see whether she's struggling or not. But looked like there was, apart from the tachypnea. So yeah, Rashid Juma, tranexamic acid should be given to bleeding patients. Shall be discussed in show. Okay. All right. So if I told you this patient's sugar level was unrecordably high, okay. So I told you, so you've seen the patient right now, okay. So I told you this patient is awake, she's slightly confused. Her sugar level is high, it just reads high. The machine is not reading appropriately. My question would be, you know her vital signs, her sugar level is unrecordably high, she has a GCS of 14, she's just slightly confused, okay? What's the immediate management for this patient? I can see we've changed a bit of our perception, which is good, all right? So that's a patient having DKA, okay? So is there a pulse? Yes, okay? Trauma? No. Is the airway, I told you her GCS is 14, okay? Airway, it's open. At GCS 14, you can maintain your airway. You do not need to be intubated when your GCS is 14 and you're just confused. Breathing, her rate was high, yes, at 30. Air entry, DKA ideally should be good, should not have any other issues. Color should be fine. Remember, her saturations were 100% on room air, so they need any oxygen. Effort, she was tachypnic, which is fine. Okay, she was tachypnic, but her tachypnea was because of acidosis, not lung problems. She wasn't tachypnic because she was struggling to breathe. She was tachypnic because she's trying to blow out all the excessive acid accumulating in her body secondary to DKA. Her saturations are fine. That means they need oxygen. If we check her circulation, rate was good. A bit of a tachy, which comes with your DKA. She's a bit dehydrated. Level of consciousness, we've put her at voice, so she's confused, so she's at voice. She's alert but confused, I guess. Color should be fine, she's not bleeding anywhere. ECG shows tachy, BPs were fine. So this patient just needs fluid resuscitation. To the question, Brian Kimutai, saturations above 94%, you do not need oxygen unless you have carbon monoxide poisoning or yes. So yes, Damaris, this patient probably has cosmal breathing. And then if sugars are high with that breathing, it's most likely DKA. So initial management will be fluid resuscitation. So for against fluid resuscitations, you are right. Hyposmolar coma, she's confused. So she's not at coma yet, because she was at coma, then we'd be talking about intubation. So right now, she's just at DKA with confusion. Yes, fluid resuscitation will be required. All right. Yes, Romeo, sneaky. Yes. All right. So you can see how it changes. And that's why it's important to evaluate each step as you go along. Okay. So let me just stop sharing that. Okay. And yeah. Yes. So you can see how it changes when you go step by step, trying to evaluate and determine. So answering these questions as you move along helps you determine what's your next step for this particular patient. And in some instances, you will be like, I'm good for now, so I can maintain my airway for now, but down the line, maybe I need to intubate. But let's move to breathing and assess that.
I need your help. He's having a seizure. Daryl? Grab his arms. Give me the oxygen.
So a friend of the dental chair lost consciousness, went into having seizures. So what's your next step, or what's your immediate concern with this patient? So we know he has a pulse, he's seizing, okay? There's no trauma, he's on a dental chair. Your next question is always, is the airway open? Okay, you still go down the same pathway. Intubation will be later. Okay, so is the airway open? If you saw the dentist is actually struggling to try and keep the jaw open. In your setting, if you have a bed, if you're on a bed, then you want to turn your patient immediately to the side so that the tongue falls forwards. And if the patient vomits, the vomit falls forwards. Is the airway open? Is still the priority in this particular patient. Because they're having seizures, that means the GCS is down. The biggest risk in a patient having seizures, of course, is your airway falling to the back of the throat and blocking your airway. So you want to turn the patient on the side. So the doctor here was doing a jaw thrust. He did not have the room of a bed to be able to turn the patient around. But if you have a bed, you want to turn the patient on the side. And I think one of the things that you probably should not be doing is trying to restrict the patient. Though again, in this setting, I think the doctor did not have enough room, and the patient was just about to break everything around. So you want to make sure you have a safe environment for the patient to have that seizure. Now, everything else comes in after is the airway open, okay? This patient will need oxygen, okay? Normally, when you're seizing, you do not breathe. And so we normally give you supplemental oxygen so that when you stop seizing, your first breath is with oxygen. So turn the patient to the side, put a face mask on them, and wait the seizure out as you get your medication. Okay, breathing will happen later. Okay, that you can only assess breathing once the patient stops seizing. Okay, if the patient doesn't stop seizing, then despite you providing them with anti-seizure medications, your midazolam and things like that, then you're still stuck at airway. And that's the next question is, am I intubating this patient? So you will actually not move to breathing, circulation, or disability. You will stop at airway until that patient either, if they stop seizing, then you're asking, is it open, maintainable, or intubate? Most of the time, they'll be at maintainable. If they do not stop seizing, then you will have to intubate this patient. You will not be able to do anything else, actually, as the patient is having their fit. So he was having a seizure, all right? So we've said he needs airway. We said the main thing is, first thing is turn him to his side. Okay, that's the first thing, like airway, 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 okay? Second thing we'll do is give him some oxygen, okay? Third thing we'll probably do then is give him some benzo, okay? So IM midazolam works good for some of these patients. In case you don't have an IV access, if you have IV access, better. But do not struggle getting an IV access in a seizing patient. You can give them IM benzos, midazolam, IM midazolam works as well. And then down the line, you will end up having to consider intubating this patient if they do not wake up or they continue having their seizures. But the first and important thing is turn them to the side to prevent such aspiration, as Kishore Kumar put it. That's correct, yes. All right, so I'm gonna this is my last presentation. We're gonna just look at a nicely done trauma case. I see a chart. If this patient was not breathing during the seizure, should we worry about brain hypoxia? So normally, this is the thing about having a seizure. Patients do not seize. I know if you ask people, I should actually maybe, if I wish I could create a poll in like a second and try and ask a question, or maybe you can answer on the chat. How long do you think a seizure lasts? Type your answer in the chat. How long is a seizure? Or how long have you ever seen a patient seize? Just put in the chat. Don't worry. There's no right or wrong answer. Zaid says less than 5 minutes. Omar seen someone seize for 10 minutes. Janet Yai, 5 minutes. William, less than 5. Boy, 15 seconds. Good one. Up to a minute. 15 continuous minutes, 2 to 3 minutes there. Less than 5 minutes. 30 seconds to a minute. Okay. 3 to 5 minutes, a minute. 2 to 5 minutes, less than 10 minutes. Interesting. So 5 minutes, less than a minute. Good, Eric. 10 minutes, seconds to 5 minutes. 5 seconds. Yep. So the thing is, a patient doesn't seize continuously for more than a minute. Okay. Them shaking around looks long. Okay. But a patient will seize for at best a minute. They will stop briefly, probably take a breath, and then continue. So no patient has continuous jerky movements for 5 minutes. There's always a pause, and the pause is a brief pause, because remember, if you think about the pathophysiology of seizures, is every single muscle in your body is firing, okay? That means also your respiratory muscle. That means you're not breathing, okay? So in essence, when you're having a seizure, you are holding your breath. You're not breathing, okay? Your body, luckily, is good enough to have mechanisms to actually self-preserve itself. So you will have your seizure. Most of the time, it's probably less than a minute. You will stop, probably take a breath or two, and then start seizing again. So you can have continuous seizures without waking up in between, but there's no one seizure that continues. So the next time you're having a patient seizing, observe as you get your midazolam. Not just sit there and watch the patient seize continuously because you want to observe this, but observe the patient. They will seize, stop, seize, stop, seize, stop. Purely because you are not breathing as you're having a seizure. So you can't get brain hypoxia because you will stop to breathe at some point. But if you continue seizing, okay, without that being terminated, eventually, because the breathing in between is not effective, eventually, yes, you will end up with brain hypoxia. Yeah, I hope that answers your question. So the definition of status epilepticus is a patient who has more than one seizure without waking up in between, okay? If you seize and you don't wake up and you have another seizure, you're in status epilepticus. So it's not about how long the seizure lasts. It's are you waking up? If I seize, I wake up, we have a chat, I seize again, I wake up, we have a chat. That's not status epilepticus. But if I seize, I remain unconscious, I seize again, I remain unconscious, that's status epilepticus. All right. So anyone who says a minute or less than a minute, you're probably correct. Yes. All right. So last one, trauma resus.
Good morning, all. This is Matt. He's a 25-year-old male. Approximately 1 hour ago, he was a cyclist versus HGV. He was GCS 15 on scene, moving all limbs. Injuries head to toe, no concerns with the head and the chest. Significant bruising over the abdomen and a closed open book pelvic fracture. Interventions, he's had a 111 RSI with a rock time of 9:56, and he's had 1 gram of tranexamic acid. He's had ongoing volume issues. He's had 2 units of blood en route, and his last systolic blood pressure with us was 85.
Okay, that's great. Thanks, Neil. Okay, guys, can we have 3 people either side? Trolley perhaps down a little bit and both sides down. So we're going to lift him. Okay, we're going to lift the scoop about 6 inches on Queenie's count, and Vish will pull out the blizzard blanket.
Okay, bracelet on online command, ready brace lift. Ready brace down.
Okay, head blocks and tape off and scoop broken, please.
Broken at the bottom.
Broken at the top.
I'm bracing from the patient's left-hand side, first of all, on Queenie's count. Okay, well done, guys. Right, can we have primary survey bloods, please?
Temperature 35.
All right, the trachea is nice and central. There's no obvious open chest injury, no surgical emphysema. The chest expansion is equal bilaterally. Percussion resonant bilaterally. Breath sounds equal bilaterally. There's obvious bruising on the anterior abdominal wall. Okay, good blood taking. Well done. That's great. Can we run that gas, please? Okay.
Chest X-ray, please. In 5, 4, 3, 2, 1. Thank you.
Okay, that's great. Guys, at the moment, he's got a blood pressure of 84. His end tidal is 4. And we've got a heart rate of 100, so I think we're probably in a situation, unless the fast is positive, that we can probably go to CT. So if we can get prepped for that, we'll get the fast done. And Nemi, you have to pop a central line in, please. Thanks.
The fast scan now, please. Thank you.
Okay. Do you mind if I do this fast scan?
Sure, go ahead.
Great.
In 5, 4, 3, 2, 1. Thank you.
Okay, I'm performing the fast scan. So looking in the right upper quadrant, no free fluid. I'm now looking in the left upper quadrant. No free fluid. I'm looking down in the pelvis. I can't see any free fluid yourself. Okay, we're just going to have a quick look in the subxiffy window. And I can't see any hemopericardium. Okay, so in summary, this is a negative fast scan.
Thanks, Will. Okay, great. We'll just get the pelvis on. Thank you. Okay, the chest X-ray, tubes in an adequate position, and on the left side of the chest we have rib fractures and a pneumothorax. So, Nick, would you prep to put a chest drain in, please, just before we go to CT? We've got a couple of minutes. Mariam, are you happy to support him? Yeah. Thank you.
Hands clear for pelvis. 5, 4, 3, 2, 1. Thank you.
Okay, that looks like a complex right-sided pelvic fracture.
Okay, so that's great. Thanks, both. Are you happy if we do CT head to pelvis? I think that's probably okay for now. And if we might need IR, so can you just let the interventional radiology team know? Is that right? Thanks. That's great.
Okay, guys, we're ready to go to CT. Everyone happy to move?
Yes.
Yeah.
All right, that's a good video just showing you need a team to resuscitate any patient, not just the trauma patient, but any patient who needs resuscitation. You need to have a team. So in the trauma system, they go through the primary survey, secondary survey, and actually the tertiary survey. They were reviewing the X-rays, they're reviewing the CT, they had the fast reviewed. So you need a team and again, you're going down the same principles of, which is what we had here in terms of assessment. I'll just quickly check what's our quality of care. Yes, we should be providing that quality of care in our own countries. Yes. More training, equipping undergarments, the ED. Well, trauma team, excellent. But trauma team is everyone you're working with in your ED. So just to summarize, 6-step process in assessing any crashing patient. Pulse, yes or no. Trauma, yes or no. Airway, is it open, maintainable? Do I need to intubate? I hope this is not clear for everyone about the different steps. Then you need to race through your breathing, rate air entry, color of the patient, effort of breathing, saturations, and race through the circulations where you have your rate, level of consciousness, the AFPU, color of the patient, what's your ECG looking like, what's your systolic blood pressure, and then disability, you normally go through what's your patient's GCS, check your pupillary response, and then your RBS. If you did this for every crashing patient, every crashing adult, you'll never go wrong as long as you resuscitate what you find as you move along.